Assalamualaikum and good morning. Welcome back to National Institute of Health Continuous Medical Education Session 2024, organised and brought to you by the Sector for Research Information Resources, Office of NIH Manager, NIH, and we are now live from NIH Studio Setia Alam. Today marks the 7th series of NIH CME for this year, and this is the platform for NIH researchers to share their findings, their experience and their knowledge to others. Alright, for those who just joined us, do register yourself in the attendance link provided in the description section. And if you have any questions, comments or feedback, key in your questions also via the link provided in the description section, and you will receive your certificate of attendance within 7 weeks after this session. Alright, before we proceed, have a look at this promotional montage.
Malaysia is currently facing the double burden of communicable and non-communicable diseases. Together with lifestyle risk factors, which pose devastating consequences on population health. Population-based data is vital for monitoring of health status of our population, while indirectly evaluating various strategies and programs implemented by the Ministry of Health. The Institute for Public Health, or better known as IKU, is one of the research institutes under the National Institutes of Health, Ministry of Health Malaysia, that spirits national epidemiological research, with the goal of supporting evidence-based policy making, through public health research and regular population-based surveys.
We started as a training institute in 1967 and changed our main focus to research in 2005 with the establishment of the National Institute of Health, NIH. As one of the research institutes under NIH, our main functions are conducting research, training and consultancy. Our niche area is community-based survey, and we are well known for our National Health and Mobility Survey, or better known as NHMS. These surveys were done at regular intervals since 1986, targeting different topics and target population.
IKU aims to strive further to become a leader in health survey in Malaysia, and to achieve this, IKU formulated 6 key strategies. IKU value knowledge as a commodity to be shared, and continuously disseminate the research findings. IKU disseminate research findings to the stakeholders through various presentations, technical reports, fact sheet highlights, and infographics. At the same time, IKU published a research findings in various scientific journals and presentations at scientific conferences.
Our officers also provide consultancies in various research-related areas. For this, I'm proud to note our expertise were recognized by numerous agencies locally and internationally.
In ensuring to provide a comprehensive health-related population-based data, IKU established 7 centers that mirrored image public health divisions at the Ministry of Health. Family health, communicable disease, non-communicable disease, nutrition epidemiology, burden of disease, occupational health, survey research.
NHMS scopes were based on either age groups such as maternal and child, adolescents and older persons, or health-related scopes such as non-communicable diseases, communicable diseases, and nutrition.
Apart from that, IKU also conducted other national survey and burden of disease study. IKU is also actively involved in interventional study, also conducted development and validation of new research tools, as well as a systematic and scoping review.
To produce quality research, we must adopt cutting-edge technologies. Facilities in IKU are equipped with research-critical equipment and systems to ensure that we produce quality research output.
Through the years, IKU has significantly enhanced its capacity as a research institute. IKU achievements can be seen through his contributions to the key performance indicators set by the top managements. We strive to be the center of excellence in epidemiological and survey research through conducting high-impact research in supporting the Ministry of Health for evidence-based policymaking.
Welcome back. Just a quick reminder for those who just joined us, do register yourself in the link provided in the description section. And if you have any questions, feedback and comments, just key in your question and I will try to read your questions towards the end of this session. And don't forget to subscribe to our NIH YouTube channel and catch us on our latest updates and events. So together with me today, I have a very special guest on board. Sitting next to me is Dr. Muhammad Azri bin Adnan. Let me have a brief introduction about him first. Okay, he is a medical officer at the Family Health Research Center, a FHRC Institute for Public Health, or famously known as IKU, National Institute of Health, Ministry of Health, Malaysia. He earned his Bachelor of Medicine and Bachelor of Surgery MBBS from the Jordan University of Science and Technology in 2014. Before taking his current role at the Institute for Public Health, which he joined in 2021, Dr. Azri gained his clinical experience by working at the Hospital Putrajaya, Klinik Kesihatan Sandakan, and he explored his research potential at the Institute for Medical Research (IMR). Since joining IKU, he has been actively contributed to several national research projects, including the National Health and Mobility Surveys, in short NHMS 2022, 2023 and 2024, as well as the Orang Asli Health Survey. His primary research interests focusing on family health, child nutrition, health outcome for children under 5. Dr. Azri is currently the principal investigator for NHMS 2022 Maternal and Child Health MCH. He had presented his scientific papers and study findings in various scientific conferences and events, and his research delves into the nationwide survey, which may have impact to the policy change for the ministry generally. We are privileged to have Dr. Muhammad Azri with us today to share his insights and findings. So please join me to welcome Dr. Azri. Without further ado, I'll pass the limelight to him. Okay.
Thank you very much for the kind introduction, moderator. Assalamualaikum and a very good morning to everyone. Hi, my name is Dr. Muhammad Azri Adam bin Adnan, Medical Officer from the Family Health Research Center, Institute for Public Health, NIH. Today, inshallah, I will presenting my topic, my CME, on the topic of results from the National Health and Mobility Survey, NHMS 2022 Maternal and Child Health. Without further ado, I will proceed with my presentation. This will be the outline of my today presentation. As an introduction, the National Health and Mobility Survey, or better known as NHMS, is a nationwide population-based survey conducted across Malaysia. It is designed to provide data that supplement routinely available data. The first NHMS was conducted in 1986, and initially it was repeated at 10-year intervals. Since 2011, NHMS has been implemented yearly with a 4-yearly cycle that cover different health aspects. In 2022, NHMS focused on maternal and child health for the second time. For everyone information, the first NHMS MCH was conducted back in 2016. Since 1970 to date, Malaysia has demonstrated significant achievement in improving the maternal and child health and survival. One of the key indicators to this progress is the reduction of under 5 mortality rate from 55 to 7.4 per 1,000 live births. However, there are still gaps remains in the delivery of MCH system. For example, the maternal mortality ratio, MMR, has been plateaued since 2000, and vaccine-preventable diseases such as measles were still sporadic. There were also concerns regarding women's sexual and reproductive health issues such as contraception uptake. In addition, children in Malaysia also facing the threat of a double burden of malnutrition, stunting on one hand and obesity on the other hand. NHMS aims to provide detailed population-based data and information which are critical in developing and justifying current evidence-based policies and programs. NHMS MCH is also one of the important key data sources for our international obligations such as SDG and UHC. In the meantime, our result can be compared with findings from NHMS 26. There were also new scopes that are being studied in NHMS 2022, such as contraception, miscarriage, intimate partner violence, and also vaccine hesitancy. So now I move on to the objective and the methodology of the survey. The general objective of this survey is to provide health-related, community-based data and information to support the Ministry of Health to review health priorities, program strategies and activities, and planning for allocation of resources for maternal and child health care. There are two specific objectives for this survey. First is to assess the health of women in their reproductive age group 15 to 49 years in relation to antenatal care, intrapartum care, postnatal care, and also reproductive health. The second specific objective of this survey is to assess the health status of children below 5 years old in relation to vaccination coverage, vaccine hesitancy, nutritional status, child development, child mobility, child discipline, and also oral health. For the methodology, NHMS targets first children under the age of 5, second mothers aged 15 to 49 years with the last child under the age of 2, and 3 women of their reproductive age 15 to 49 years whom resides in a non-institutional living quarters or LQ in Malaysia. The inclusion criteria for LQ for children under 5 and mothers with last child under the age of 2 is the household member of the LQ having at least one children under the age of 5 years old whom stayed at the LQ for at least 2 weeks prior to data collection. For the inclusion criteria of LQ of women of reproductive age, the household member should at least have one woman aged 15 to 49 years whom also stayed in the LQ for at least 2 weeks prior to data collection. The sampling frame of the survey is based from the National Population and Housing Census 2022. NHMS is a cross-sectional survey with a complex survey analysis. To ensure national representativeness, we use two-stage stratified random sampling as the sampling design. The two strata is made up of first the primary stratum and second the secondary stratum. The primary stratum is made up of all states including the federal territories in Malaysia, while the secondary stratum is made up of urban and rural area formed within the primary stratum. The sampling stages involve two stages. The first is the primary sampling units, which is the enumeration blocks. The secondary sampling units are the living quarters from the selected enumeration blocks. For NHMS MCH, a total of 1,029 enumeration blocks that was randomly chosen by DOSM, and a total of 13,832 living quarters involved in our survey. The sampling design of this survey are targeted for two populations. The first sampling design is aimed for children 0 to 59 months and mothers aged 15 to 49 years with the last child under the age of 2, which is for the MCH modules. Prior to data collection, listing activities were conducted by trainers to identify the eligible LQ. The second sampling design is aimed for women of reproductive age 15 to 49 years for the women reproductive age modules. A total of 700 EB equivalent to 50 EB each stage were randomly selected. 4 LQ from each EB equivalent to 2,800 LQ were sampled. only one respondent per LQ was interviewed for this design. However, if multiple eligible women were present, the respondent was randomly selected using the quiche method. This slide shows the survey instrument. NHMS MCH used a set of structured validated questionnaires that was administered through face-to-face interview and also self-administered questionnaire SAQ. For the face-to-face interview, as the topic listed on the slide, the tools that were used were adapted from UNICEF, the Multiple Indicator Cluster Survey or MICS. The Edinburgh Postnatal Depression Scale, the Parents' Attitude About Childhood Vaccines, PACV, MICS, and also WHO Women's Health and Life Experience Questionnaire were the tool used to measure postpartum depression, vaccine hesitancy, miscarriage, and intimate partner violence. For clinical assessment, there are topics on anthropometry measurement and child developmental assessment that were conducted by trained nurses. Next, we move on to the general finding of the survey. The data collection phase for NHMS MCH was conducted for 82 days from 9 August to 30th October 2022. A total of 13,832 LQs and 17,176 respondents involved in this module, with an overall response rate of 74.9%. As we can see from the slide, the majority of the children under 5 are from urban localities of Malay ethnicities and Malaysian citizens. The distribution of age and sex were evenly distributed. This slide shows the respondent characteristic of mother. A total of 6,360 mothers were interviewed. The majority of the mothers are from urban location of Malay ethnicity and Malaysian citizenship. The age group from 30 to 34 years is the highest in the age group. Majority of the mothers were married and either unpaid worker, housewife, not working, or student. In terms of education level, 48.3% of the mother completed their secondary education. This slide shows the respondent characteristic for respondent of the woman reproductive age module. A total of 1,987 eligible LQs were visited from the 2,800 LQ sample. A total of 1,877 respondents were successfully interviewed with an overall response rate of 86.6%. The majority of the respondents were from urban location, of Malay ethnicity, and Malaysian citizenship. Most of the respondents were married or cohabiting and is either unpaid worker, housewife, not working, or also student. The majority of the respondents have their secondary education completed. Now let's move on to the key findings of the survey. I will divide my findings into 3 modules. First is the maternal care. This slide shows the indicator of adequate antenatal care visit received. This is one of the tracer indicator for under the SDG 3.8.1 coverage of essential health services. Adequate antenatal care is defined as pregnant mothers who receive at least 4 or more times of antenatal care during the pregnancy. The prevalence was reported to be at 98.1 in 2022, which is higher when compared to NHMS 2016, which reported 97.4. Recently, WHO has updated its recommendation from a minimum of 4 antenatal care to 8 antenatal care to reduce the perinatal mortality and to improve women's experience of care. This slide shows the timing of first antenatal care visit. 77% of the mothers reported the first antenatal care was done in the first trimester. Subsequently, the prevalence of first antenatal care visit at second trimester and third trimester was 21.7% and 1.47% respectively. According to WHO, all pregnant mothers are recommended to have their antenatal care booking visit within the first trimester. This slide shows the prevalence of adolescent pregnancy. The prevalence of current adolescent pregnancy and the prevalence of history of adolescent pregnancy show a reduction when compared to 2016. The prevalence of current adolescent pregnancy reduced from 6.8 to 2.0, while the prevalence of history of adolescent pregnancy reduced from 16.7 to 11.6 in 2022. Current adolescent pregnancy refers to a pregnancy that occurs among mothers aged 15 to 19 years within the last 2 years at the time of data collection, while history of adolescent pregnancy refers to mothers aged 20 years or older who had a history of first pregnancy before the age of 20. The prevalence of hypertension in pregnancy and gestational DM saw an increment from 2016 to 2022. The prevalence rose from 5.8 to 6.5 for hypertension in pregnancy, while the prevalence rise from 13.5 to 27.1 for the prevalence of gestational DM. In the positive note, as we can see, the prevalence of anemia in pregnancy declined too. This slide shows the indicator of safe delivery. This indicator aligns with SDG 3.1.2, which tracks the percentage of births attended by skilled health personnel. Safe delivery is defined as birth attended was 98.4, a slight reduction when compared to the result in 2016, which reported 99.5. The prevalence of safe delivery that was reported WHO target of 90 and the national target of 95%. This slide shows the indicator of place of delivery. This is one of the UHC indicator which tracks the proportion of deliveries in health facility. Our survey reported that the prevalence of health facility delivery was 98.2, slight reduction from 99.1 in 2016. One of the possible reasons for this decline is the impact of COVID-19 from 2020 to 2022. This slide shows the timing of birth notification to the nearest health facility. As we can see, the majority of mothers notified their childbirth to the respective health facility, in which 77.8% done that within the 24 hours. Additionally, the prevalence of mothers who did not notify was at 2.8%. The prevalence of postnatal home visit within 24 hours of birth notification was reported to be at 79.1% in 2022. This figure is lower when compared to figure in 2016, which reported 91.2%. Optimal postnatal care should be carried out as soon after delivery. For continuous medical care, all deliveries must be notified to the respective health clinic. The staff in the health clinic must take action within 24 hours of receiving the notification as stated in the 4th Perinatal Care Manual. This slide shows the indicator of mothers receive 3 scheduled postnatal home visits. The prevalence of mothers who receive 3 scheduled postnatal home visits, at least 1 visit per 1 week, was reported at 63.5% in 2022, a reduction compared to result from 2016, which reported the prevalence was at 78.2%. This slide shows the indicator for postnatal depression. The prevalence of postnatal depression saw a decline from 12.7 in 2016 to 10.4% in 2022. Postnatal depression is defined as mothers with positive Edinburgh Postnatal Depression Score or EPDS among mothers 6 to 16 weeks post-delivery. A positive EPDS is defined as of EPDS score of 12 or more, or those mothers who score more than 0 on the suicidal item. The postnatal depression management was addressed in the 2nd edition of the National CPG for Major Depressive Disorder. The guideline recommends that screening for postnatal depression to be done between 6 to 12 weeks postpartum. Next, we proceed with the module of child health. This slide shows the indicator for early initiation of breastfeeding. Early initiation of breastfeeding is defined as placing the newborn to the breast within the first hour after birth. The prevalence was reported to be at 61.1% in 2022, a slight reduction from 2016, which reported 65.2%. For this indicator, there is a slight difference in study population, where in 2016 included child 0 to 6 months, while in 2022 included child 0 to 23 months. WHO recommends early initiation of breastfeeding as it protects newborns from infection and reduce newborn mortality. It also stimulates breast milk production such as the colostrum, which is important for the immunization of the baby. This slide shows the complementary feeding indicators. Minimum meal frequency or MMF is defined as children aged 6 to 23 months who consume solid, semi-solid or soft food at least the minimum number of times during the previous day, while MDD or minimum dietary diversity is defined as children who consume foods and beverages from at least 5 out of 8 defined food groups during the previous day, while the definition for minimum acceptable diet or MAD is defined as children who consume a minimum acceptable diet during the previous day. As we can see from the slide, there is an increment in the prevalence of minimum dietary diversity and the minimum acceptable diet from 46 to 64.3 and from 53.1 to 60.2. However, the prevalence of minimum meal frequency show a reduction from 80 to 78.6%. This slide shows the prevalence of children that has never been examined at a dental clinic. It was reported that the prevalence was 60.8 in 2022. This figure is lower when compared to results from 2016, which reported at 73.3%. The pie chart beside show the reason that the mothers given for not bringing child to dental clinic. More than half of the mothers give the reason that their children has no dental problem, while 22.6% of the mothers reported that their child is too young to get treatment as the main reason for not bringing their child to dental clinic. Parents often have the misconception that they should bring their kids to dentist only when there is a problem. This is incorrect. It was recommended that the first dental visit should be done by the age of 1, and yearly checkup is recommended for toddlers aged 2 to 5 years old. The prevalence of diarrhea and acute respiratory infection was reported to be at 3.1% and 1.4% in 2022. The prevalence of diarrhea had a slight reduction from 4.4, while acute respiratory infection prevalence rose from 1.5 to 1.4. Diarrhea is defined as children that have 3 or more episodes of loose or watery stools per day or blood in stool in the past 2 weeks prior to data collection, while acute respiratory infection (ARI) is defined as children with history of ARI symptom within the past 2 weeks prior to data collection. According to WHO, diarrhea and acute respiratory infection are the two of the leading causes of morbidity and mortality among children under 5 worldwide. This slide shows the indicator of child discipline among children aged 12 to 59 months. As we can see from the slide, there is a slight reduction in the prevalence of physical punishment and any violent discipline from 55 to 40.6 for physical punishment and 70.8 to 66.6 for any violent discipline. However, there is a slight increment in the prevalence of psychological aggression from 57.8 to 58.1. This is the first national data on vaccine hesitancy in Malaysia. Our survey reported that the prevalence of vaccine hesitancy was at 4.9. This figure is lower when compared to a study done locally in a hospital among mothers, which reported that the prevalence was at 11.6. Vaccine hesitancy defined as delay in acceptance or refusal of vaccine despite the availability of vaccine coverage measured by the parents' attitude about childhood vaccine PACV. A positive vaccine hesitant parents is defined as respondent who scored more than or equal out of 100. More than or equal of 50 out of 100. This slide shows the prevalence of nutritional status among children. This aligns with SDG 2.2.1, which measures the prevalence of stunting among children under 5, and SDG 2.2.2, which measures the prevalence of malnutrition among children. Nutritional status for children below 5 was assessed by, first, weight for height, second, height for age, and 3, weight for height based on the WHO growth standard. As we can see from the slide, there is an increasing trend of the prevalence of underweight and wasting. We can see the prevalence of underweight rise from 12.4 to 14.1 to 15.3 in 2022, while the prevalence of wasting increased from 8 to 11 in 2022. The prevalence of overweight also show an increment from 2019 to 2022 from 5.2 to 5.6. However, there are a slight reduction in the prevalence of stunting from 21.8 to 21.2. However, this prevalence remains very high. This table shows the global nutritional status prevalence among children under 5. As we can see from the table, the prevalence of stunting and overweight that was reported in Malaysia in 2022 was comparable to the global prevalence in 2022. However, the prevalence of wasting is higher when compared to the global prevalence, which reported at 6.8. In addition, the prevalence of wasting is higher when compared to those Asian countries as listed in the table. Next, we go to the prevalence of primary vaccination coverage among children 12 to 23 months. This indicator aligns with SDG 3.B.1, which track the percentage of target population covered by all vaccines included in their national program. The prevalence of complete primary vaccination saw a reduction from 95.3 to 87.1%. Complete primary vaccination is defined as children who completed their vaccination verified through their health book clinic, plus the children who complete their vaccination reported by the guardians. As we can see from the stack bar, the prevalence of verified complete and self-reported complete saw a reduction from 86.4 to 83.5 and self-reported from 8.9 to 3.6 in 2022. Inversely, there is an increment of 3 times for the prevalence of incomplete vaccination from 4.5 to 11.9, and unvaccinated prevalence increased by 10 times from 0.1% to 1%. Next, to the module of women reproductive age. This indicator relates closely to SDG target 3.7, which by 2030 to ensure that universal access to sexual and reproductive healthcare services, including family planning, information and education, and integration of reproductive health into national strategies and programs. It was reported that the prevalence of any contraceptive method was at 42.8%, at which 34.5% of the mothers using the modern contraceptive method. The modern contraceptive method is defined as female and male sterilization, uterine device, IUD, injectables, implants, pill, male and female condom, diaphragm, foam or jelly, and lactational amenorrhea method, LAM. This slide shows the indicator for unmet need for family planning and demand for family planning satisfied with modern method. This track the indicator of SDG 3.7.1, which track the proportion of women of their reproductive age who have their needs for family planning satisfied with modern methods. The unmet need for family planning is defined as the percentage of mothers of women reproductive age, either married or in a union, who wants to stop or delay childbearing but not using any method of contraception, while DFPS is defined as percentage of women who desire to have no children or to postpone the next children, and they are using currently a modern method of contraception. In our survey, it was reported that the prevalence of unmet need was 26.7, while the prevalence of DFPS was 51.6%. In comparison to neighboring countries as listed in the table, our prevalence was highest when compared to Indonesia, Cambodia, Philippines, and also Timor-Leste. This slide shows the indicator of intimate partner violence by type of violence. This aligns with SDG 5.2.1, which measures the proportion of ever partnered women aged 15 to 49 years who are subjected to physical, sexual, or even psychological violence by a current or former intimate partner in the previous 12 months. It was reported that the prevalence of past year any violence was at 4.4%, while the lifetime intimate partner violence was reported at 7.1%. The prevalence of sexual, physical, and psychological violence for the past year was at 0.8, 1.6, 3.5, and 3.5 respectively. So now we move on to the key highlights and the recommendation. These are the 5 key highlights from my presentation. First is the high prevalence of stunting and wasting among children. Second, reduction in the prevalence of verified complete primary vaccination coverage from 86.4 to 83.5. Number 3 is reduction in the prevalence of mothers receive 3 scheduled postnatal home visits from 78.2 to 63.5. 4. The prevalence of postnatal depression, which remain high at 10.4. And last, the high prevalence of unmet need for family planning at 26.7. For the recommendation, the high prevalence of stunting and wasting among children requires urgent attention. It is important for healthcare providers to motivate parents and caregivers to regularly monitor their children's growth at home and bring them to their routine health checkup. In addition, we should educate and empower caregivers in providing variety of healthy foods starting at the age of 6 months to ensure adequate nutrition. We should also strengthen the food and nutrition security through a more holistic and sustainable approaches, which is one of the key to address the malnutrition issue. To address the reduction in complete primary vaccination coverage, following the pandemic, intense effort has been conducted to trace defaulters and children who missed their vaccination. In addition, healthcare provider should maximize the use of NIP MyVAS system, which has been implemented at all levels, including the private sector, to improve the vaccination documentation. Lastly, advocacy and educational program should be strengthened, which to focus on the importance of vaccination for children. To tackle the issue in the reduction in prevalence of received 3 scheduled postnatal home visits from 78.2 to 63.5, especially post-pandemic, we should focus or widely utilize the remote consultation such as virtual consultation and telephone checkup to ensure the continuity of postnatal care. In addition, healthcare providers should emphasize the mother on the importance of early notification of delivery so that postnatal care can be promptly arranged. For the high prevalence of postnatal depression, we should develop a structured postnatal mental health program. This program should include early screening to detect early cases and a clear pathway or algorithm for the intervention, and also increase in promotional to spread awareness among mothers. Focus also should be on the prevention activities to prevent the risk of postnatal depression. The high prevalence of unmet need for family planning indicates a gap in sexual and reproductive health issues. We should focus on expanding the availability and the affordability of modern contraception, focusing especially on long-acting methods such as implants. In addition, targeted intervention and policies should be developed to address the barriers which may increase the uptake of the contraception. The full technical report of NHMS MCH are available at the IKU website. There were also infographic and also fact sheet in bilingual language. I would like to thank NHMS Steering Committee, Ministry of Health, the IKU, and my colleague from Family Health, Dr. Shaiful Azlan, as the main principal investigator of NHMS MCH, our research team member, liaison officer, data collectors, and also not to forget the respondents whom have made this survey a success. With that, I thank you.
All right. Thank you, Dr. Muhammad Azri. I must congratulate you for a very smooth conduct of your study. And for our viewers' information, Dr. Azri's study was funded by Ministry of Health Research Grant, or in short, MRG. So for those who would like to apply for the grant and be like Dr. Azri, you are most welcome. All right. Okay, so are you ready to take up any questions?
Inshallah.
Okay. I'm going to take up our first question, but we have a very limited time left. We'll try our best to answer your questions. Okay, the first questions come from Miss Anizan binti Selamat. So the question is that compulsory for 1-year-old children to visit dental clinic for fluoride treatment? And the second one is that children having iron deficiency will affect development, growth and weight?
The first one, I personally, as I'm a medical officer, so I'm not at the very best to explain regarding dental suggestion. But as I read through one of the books, it is suggestive for children under at the age of 1 to have their first dental checkup. However, this can be confirmed or checked back with my fellow dental officers, which knows best regarding this issue. And the second one?
The second one is that children having iron deficiency will affect development, growth and weight.
For this question, of course, iron anemia will affect the growth and the development of children, but it depends especially on the severity of anemia. But however, we should tackle the issue of anemia, which is also one of the malnutrition issue in Malaysia, which if we can tackle this issue, will of course the children will have a healthier outcome.
Okay. So next question from Ms. Nurul Nabila. The first one, why has the primary vaccination coverage has dropped from 2016 to 2022?
Of course, this study we don't. It's a cross-sectional study, so we don't have the causal effect. But maybe as we conduct the NHMS 2022 in 2022, so that time was the COVID pandemic struck Malaysia or worldwide. So this is maybe the reason of the drop of a reduction in primary vaccine coverage, and also maybe we know that we are having a battle of vaccine hesitancy. So I think the awareness among new mothers or new parents especially has decreased. So we should strengthening to promote awareness especially among new mothers to complete their vaccination.
Okay, so the subsequent question is, what measures have the KKM taken to address this issue?
I think the KKM has done a lot. As I mentioned before in the slide, the KKM has improved or increased the effort to trace defaulters and also to trace children who are missing their vaccine. Also, I think KKM has slowly increased when they have increased their program to spread awareness, and also maybe the KKM have a collaboration especially with the NGO to promote a vaccine among the population.
Okay, I'm going to take a last question from Dr. Nurliza. The first one, what are the plausible reasons for the high prevalence of stunting among children under 5?
I think one of the main reasons of the adequate of knowledge regarding child nutrition, because the infant, child and feeding practice is one of the key to address malnutrition issues in Malaysia. So I think one of the possible reason is the lack of knowledge, especially to new parents regarding the inadequate nutrition that should be given to children. That could be one of the main factors.
So what actions will be taken by the ministry to overcome this issue?
I think especially the nutrition division has come up with multiple strategies. In one of them is the revised Malaysian Nutrition Policy 2.0 that incorporates updated strategies which focus on to improve the national nutritional status among children. And also I think there is establishment of a group that will fight the issue of double burden malnutrition, which is being led by the Yang Amat Berhormat Timbalan Perdana Menteri. I think that's one of few of the steps that have been taken by the government.
Okay. Actually, I have a few questions in the list, but with respect to time, I think we're going to end this session in a minute. So, the list of questions will be answered by Dr. Azri later personally. He will answer the questions which I have in my hands now. But as for now, we have to stop the session. So thank you, Dr. Azri, for sharing with us your findings today. And don't forget to join us again tomorrow with different speakers and different topic, the same time and the same channel. Also, don't forget to subscribe to our YouTube channel and catch us on our latest event and updates. So till we meet again, see you tomorrow. Bye-bye.
Bye.